Menopause is defined as the permanent cessation of menses. It is diagnosed retrospectively after a woman has experienced 12 months of amenorrhea without any other reversible cause. The average age of menopause is 49 to 51 years old. Singaporean women currently live on average to 85 years. This equates to about 35 years or 52% of a woman's life in the transition and menopause stages. Hence, it is important to understand menopause in detail. Menopause reflects the near or complete depletion of ovarian follicles in the ovaries. With no follicles for the pituitary hormones to stimulate, estrogen and progesterone levels fall, leading to an increase in follicle-stimulating hormone and luteinizing hormone. The menopausal transition, or perimenopause, is characterized by irregular menstrual cycles, endocrine changes, and symptoms such as hot flushes. Menopause before age 40 years is abnormal and is referred to as primary ovarian insufficiency and is secondary to primary ovarian failure, surgery, chemotherapy, or radiotherapy. All women with primary ovarian insufficiency have increased risk of cardiovascular disease, osteoporosis, dementia, and early death if estrogen is not replaced. A woman in the menopausal transition or perimenopause can present with the following signs and symptoms: irregular menses or secondary amenorrhea, vasomotor symptoms in the form of hot flushes and night sweats, psychological changes such as anxiety and depression symptoms, which may affect memory and concentration, and disturbances in sleep patterns. Perimenopausal women may also experience physical symptoms such as feeling dizzy or faint, pressure or tightness in the head or body, loss of feeling in hands or feet, breathing difficulties, and joint pain. They may also experience sexual dysfunction, as the lack of estrogen may lead to itching, dryness, discomfort and dyspareunia, loss of desire, and orgasmic difficulties. Urogynecological symptoms are often a later presentation, with symptoms of an overactive bladder like increase in frequency, urgency, urge incontinence, and nocturia being common. An increase in urinary tract infections, stress incontinence, and dysuria may also occur, along with brittle nails, thinning of skin, and hair loss. The Stages of Reproductive Aging Workshop staging system provides a framework for assessing fertility and symptoms. In the late reproductive years, usually age 40 and above, follicle-stimulating hormone levels increases, estradiol remains steady, and luteal progesterone decreases. Ovulation occurs, but the follicular phase shortens, so overall cycle length decreases, example from 28 to 23 days. Menopause transition typically occurs around 47 years of age. In the early transition, follicle-stimulating hormone levels fluctuate and cycle length increases from 3 to 4 weeks to 5 to 7 weeks. The late transition usually lasts 1 to 3 years. Cycle length increases further with skipped months and episodes of amenorrhea. Bleeding can be light or heavy, short or prolonged. Menopause. The final menses is determined in retrospect, with follicle-stimulating hormone levels remaining high and sustained. A detailed history should be elicited, including all the symptoms, menstrual history, past medical history like chronic medical conditions and surgeries, family history of cancers and other illness, history of smoking and alcohol, and other relevant history. Have a low threshold to examine women with pelvic or abdominal pain, abdominal swelling, bloating, urinary urgency or increased frequency, a feeling of fullness and a loss of appetite and unexplained weight loss or gain. These symptoms are associated with ovarian cancer. General examination. Record height, weight, body mass index, blood pressure, and waist circumference. If a woman has breast, abdomen, or pelvic symptoms, she needs detailed examination and reporting. Asymptomatic women do not necessarily need examination. Blood tests to confirm menopausal status include the following: measuring follicle-stimulating hormone levels in older women with regular menses is unreliable to confirm menopausal status, but is useful in women where menstrual cycle cannot be assessed. For example, women who have undergone procedures like hysterectomy, endometrial ablation, or amenorrhea associated with progesterone-only contraception. Inhibin B, an anti-Müllerian hormone, are used to assess ovarian reserve in assisted reproduction but have not been validated as predictors of menopause. A amenorrhea panel in younger women with irregular menses or secondary amenorrhea can be used to diagnose premature ovarian insufficiency after excluding a pregnancy. Maintaining a healthy lifestyle, such as maintaining a healthy weight, regular exercising, with balanced diet, can help in management of menopause symptoms. Other general measures include wearing lighter layers, sleeping with air conditioning or a fan, avoiding or reducing stress, and reducing intake of spicy foods, caffeinated drinks, and alcohol. The following are non-hormonal treatments available for the management of menopause. Hormone replacement therapy. For menopause transition in women with uterus, a monthly cyclical hormone replacement therapy may be prescribed where estrogen is taken every day for 21 to 28 days and a progestogen is added in for 12 to 14 days. This causes a regular light bleed. Women in postmenopausal with a uterus can use continuous combined hormone replacement therapy where both estrogen and progestogen are taken every day so no bleeding occurs. Continuous combined hormone replacement therapy can be started after taking cyclical hormone replacement therapy for 12 months if it has been 1 year since last menses or 2 years if the woman is under 50 years of age. Perimenopausal or postmenopausal women without a uterus can take estrogen daily as the hormone replacement therapy. Estrogen can be taken as a pill, patch, or gel. The progestogen can be delivered as a pill or an intrauterine system. Tibolone or Liviol is a synthetic steroid with estrogenic, progestogenic, and androgenic effects. This can be used in women who are postmenopausal with or without a uterus. Risk of stroke may be doubled with use beyond 60 years. It is important to understand the benefits and risks of hormone replacement therapy to decide if it is suitable for you. The benefits of hormone replacement therapy include improving hot flushes and night sweats, improving bone mineral density, reducing dryness in the vagina, reducing pain during intercourse, reducing urinary tract infection, reducing overactive bladder symptoms, improving mood and sleep, improving joint pain, reducing risk of bowel cancer and colorectal cancer. The risks of hormone replacement therapy include having the window of opportunity for coronary heart disease if taken in the first 10 years of menopause or under 60 years of age, having a higher risk for breast cancer if both estrogen and progestogen are used together. Estrogen-only hormone replacement therapy has little or no risk. Having a slightly increased risk for ovarian cancer that returns to baseline on stopping treatment. Increased risk for endometrial cancer. Small risk of stroke associated with women over the age of 60 years old. Higher risk of venous thromboembolism with estrogen and progestogen hormone replacement therapy compared with estrogen-only hormone replacement therapy. Women with the following medical history and conditions are not suitable for any hormone replacement therapy. Women with the following medical history and conditions should seek a doctor's opinion on hormone replacement therapy. Personal or family history of venous thromboembolism, history of myocardial infarction, angina and stroke, uncontrolled blood pressure, severe liver disease, undiagnosed breast lump, uninvestigated vaginal bleeding. Hormone replacement therapy has the following common side effects. However, most side effects are transient and settle by 3 months. They include headaches, nausea, leg cramps, dry eyes, and skin pigmentation. Changing to a different preparation or delivery system may help with the side effects. It is important to note that hormone replacement therapy is not contraceptive, as the dose of estrogen is not high enough to suppress gonadotropins. Contraception should be continued for 2 years after the last menses if the woman is under 50 years of age, and 1 year if the woman is aged 50 or above. Women with premature ovarian insufficiency should receive estrogen replacement until the average age of the menopause, which is at 50 years of age. For women taking hormone replacement therapy beyond 50 years of age, the most consistent advice is to take the lowest dose possible for the shortest time. Most menopausal symptoms improve over 1 to 3 years, so hormone replacement therapy can be stopped to assess for symptoms improvements or changes. Women who suffer from vaginal dryness can use the following remedies: personal lubricants, either aqueous or silicone, vaginal moisturizers, oils, or vaginal estrogen. Vaginal estrogen can be continued long-term with no increased risk of endometrial cancer. Long-term effects of estrogen deficiency include osteoporosis and an increased risk of cardiovascular disease due to an increase in cholesterol, low-density lipoprotein and triglycerides, and a decrease in high-density lipoprotein. There is, however, insufficient evidence to link dementia, degenerative arthritis, and weight gain to long-term estrogen deficiency. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.